Hello, everyone. My name is Shad Yassin, and I'm a first-year medical student at Rutgers, New Jersey Medical School, as well as a member of the Standing Committee on Legislation and Advocacy. Today, we're going to be discussing the subject of why housing matters in health. And after this presentation, we're going to have a Q&A panel with three fantastic speakers. We have Dr. Kelly Doran, an emergency medicine physician and associate professor of emergency medicine and population health at NYU Grossman School of Medicine. We have Dr. Elena Boyer, who's a director of research at the National Healthcare for the Homeless Council, and Dr. Robert Fullylove, who's the associate dean of community and minority affairs at Columbia University Mailman School of Public Health. So I'd like to start off with just talking a little bit about the state of homelessness today. There were 580,466 individuals estimated to be experiencing homelessness on a single night in January 2020. This is a large population of people who lack just the fundamental need of housing. Compared to previous years, homelessness is on the rise. Since 2019, there's been a 2.2% increase in the overall homelessness rate. There's also been an increasing trend since 2016, where between 2016 and 2020, there have been over 30,000 people added to this population. Demographically, while the majority of people experiencing homelessness are adults, there's a significant percentage of children in that mix. 18.3% of people experiencing homelessness are 18 years old or younger. There's also a major racial disparities within homelessness. 39.4% of all people experiencing homelessness identify as Black or African American, which is a much higher proportion than their overall total US population. A significant contributor to this increase in homelessness revolves around the issue of sheltered versus unsheltered homelessness. So sheltered homelessness is basically where people have access to emergency shelters, transitional housing programs, or safe havens, whereas unsheltered homelessness is where people don't have access to these facilities, and they primarily sleep in locations that are not designated for sleeping. This includes private and public property, places like their car, the streets, parks, and many other locations. While the majority of the homeless population, 61%, is sheltered, we are seeing large discrepancies in their rates in recent years. Since 2019, there has been a 0.6% decrease in sheltered homelessness compared to a 7% increase in unsheltered homelessness. So not only are we increasing the overall numbers of the homeless population, the people who are being added don't have access to facilities that protect them from even worse morbidity and mortality rates that are associated with unsheltered homelessness. Is a very brief history of homelessness. It's been around essentially in this region of the world since Europeans first colonized it. The Native Americans were the first population to be homeless due to their forced displacement by the Europeans. Housing issues remained in both of these populations basically throughout the 1800s. As the now newly independent Americans moved westwards, they displaced more Native Americans and had a lack of housing infrastructure as they moved west. When the Great Depression hit in the 1930s, there were massive amounts of homelessness throughout the country. And this is where President Roosevelt's New Deal policies played in. In 1934, the Federal Transient Service was established, and that provided shelters, jobs, meals, and medical and dental care for over 400,000 people experiencing homelessness. It was a successful program that dramatically reduced homelessness. But as the country was doing economically better, these programs were cut. And in the 1960s, due to a movement to create highways and neighborhoods, which was called urban renewal, there were many more people displaced because of that. And so further budget cuts happened as veterans returned from war in the 1970s. Social programs weren't favored by conservative administrations of the 1990s. And so now we have an increasing growth in homelessness. Fast forward to the 2000s, where we have an already growing homeless population, housing prices are increasing, and wages are failing to keep up with that. The Great Recession creates an immense financial burden for people, and homelessness increases significantly. As this happens, we have an increasing movement to criminalize homelessness as well. And this is where we have this population of unsheltered homeless people who are unable to simply live their lives without being harassed by police. So now I want to get into the second subject of this talk today, and that's redlining. At its core, redlining was the systemic denial or selective raising of prices on financial services such as mortgages, loans, and they essentially targeted lower income communities and specifically communities of color. This is what a redline map would look like. The green portions would mean that they were the best people, quote to quote, such as businessmen. The blue sections meant that it was white collar families, yellow meant working class families, and red meant, to quote, detrimental influences, foreign-born people and Black families. And these, I want to mention, or I want to emphasize, are the legal government-sponsored designations of communities around the United States. And so how did this really happen? Well, in 1934, with the same social programs that came in the New Deal, came the National Housing Act. And this was meant to provide low interest mortgages, to provide affordable housing for people in the aftermath of the Great Depression. And so many of these social programs did wonderful things. However, like many of the social programs during this time, they only targeted white people. And so the Homeowners Loan Corporation, or the HOLC, was established, and they created these designations for these communities. And these designations determined the mortgage rates that were given to these people. They created residential security maps, like the one we just saw, for 239 of the largest cities in the United States. Through this, they were able to prevent African Americans from getting fair rates on loans, preventing many from purchasing property and building their communities. 34 years pass, and people within these communities are unable to build wealth and reinvest in the community. In the aftermath of the death of Dr. Martin Luther King Jr. in 1968, the Fair Housing Act was passed, and this encouraged equal housing opportunities regardless of race. However, the issue with this was that it only protected against future practices. And so now we're going to go into a lot more depth with all these topics in the Q&A. And so I just wanted to thank you all for your attention. And let's get started with the Q&A. So Dr. Doran, Dr. Fullylove, Dr. Boyer, thank you all so much for joining. I wanted to start off the Q&A with a question for you, Dr. Fullylove. And that question is, what is the impact of the environment, including city planning, pollution, zoning codes, on the health conditions of residents in historically redlined areas? And more specifically, how has this affected children?
Well, more than anything else, we measure its impact through factors like lower life expectancy. Live in one of these neighborhoods in many urban communities, and you'll discover that your zip code has a life expectancy that's 6 to 10 years less than what it is for mainstream populations. We're very clear that this is not a function of the genetics of the people who live there. This is literally a function of the interactions between individuals and their environment. It's unhealthy.
Thank you. Yeah. The next question I have is for you, Dr. Doran. Among people experiencing homelessness, what conditions do you often see in the clinical settings, and what conditions are exacerbated by their housing status?
Thanks, Shad, and thank you for organizing this panel. The first thing I would tell just the medical students listening especially is just to remember that people experiencing homelessness, they can present to the hospital, to the emergency department, to the clinics for all the same health problems that everybody else can. So, you know, just because somebody's homeless doesn't mean that they're not going to come into the emergency department with a heart attack, with appendicitis. And so that's really important to note. But there are several conditions that we do see more among people experiencing homelessness that are exacerbated by the condition of being homelessness itself. One of the most common ones that we see in the emergency department, I'm an ER doc, I work in a city hospital. We see a lot of people coming in with infections of their lower extremities, of their feet and their legs, in part because they're on their feet all the time. They might not have access to adequate socks and shoes. They might have uncontrolled diabetes or other conditions. And just that's something where the condition of homelessness itself really makes it hard to not develop some of these infections in your legs. And it can sometimes get to the point where, unfortunately, we've even seen people who have to have their legs amputated. We also see during COVID, for people in homeless shelters in particular, we saw a lot of COVID because the risks of being all together in one congregate setting where you're sleeping 10 people in a room, COVID can spread more easily in that type of setting, as can other infectious diseases. And so we see that too. And last, I just note we see a lot of trauma as well, different types of trauma that people experience, either being in a shelter where people will sometimes come in after assaults, or being on the streets where people are also subject to assaults, physical violence, sexual violence, and other accidents.
And just to follow up on that, some of the things that we're also hearing now from a research lens is the impact of sleep deprivation and how that impacts all of these conditions. Oftentimes, an individual who might be unstably housed is getting 2 to 3 hours of sleep a night, if they sleep at all, depending on the environment they're in, if they feel safe or not. And just thinking about the level of sleep deprivation has on confusion, on health, it impacts, how an individual might respond to either a police officer coming up to them. Might not be because of, everything that is going on, but rather the fact that there's sleep deprivation, but it might appear as confusion or those types of things as well. So I'm sure that probably also impacts what we're seeing in the health centers as well. I would also add what we're hearing a lot is we're seeing a lot of addiction and opioid type related incidents as well, which again, it's because of failures of systems, not the individual. So just thinking about that from a larger systems perspective and its impact on health. Just wanted to add that bit.
Thank you both for that. Going off of that, Dr. Boyer, could you tell us a little bit about medical respite care and what really is medical respite care and what is the status of that in the United States?
Yeah, absolutely. So this is something that is currently growing. It's something that kind of came out, it was born from the National Healthcare for the Homeless Council, really drove this program and has developed standards. But really what medical respite care is really caring for and allowing for spaces and environments for people to recover if they've been in the hospital. So really it's for individuals who are not sick enough to stay in the hospital, so they get discharged without a place to go, but aren't well enough to recover in a street environment or a shelter environment. So really what medical respite places are is really for, someone to recover in decency and dignity, receive care. It's short term, it's not a long-term residential facility, but really it's supposed to really serve as a transition of care and care coordination and linkages to care. So we can continue either providing medications that they might need, they have nutrition and food that they might need. There are also opportunities to improve self-management in the spaces that they live in, because that's going to look different than a housed person. So, how do you maintain or continue your medication management if you're diabetic but have to go back out on the street or you don't have refrigeration? So, really kind of tailoring the needs and self-management can happen in those spaces of medical respite programs. The thing with medical respite programs is that they're very diverse and they look very different. They can be in different settings. They can be in old hotels. They can be, a part of a health center. So some of those things are important in thinking about the national scope of medical respite programs. Staffing can look different. It doesn't necessarily have to be skilled nursing or those types of things, but again, it's continued care after discharge from a hospital. And currently, I believe there are nearly or just over 100 medical respite programs right now. We just launched the National Institute of Medical Respite Care that has a lot of information on that as well. So it's definitely getting some traction and movement. It is different from hospice. It is not hospice. So we really try to make that clear. But it's a really powerful place for individuals to continue wound care and those types of things. If somebody is getting chemotherapy, you don't feel well sometimes and you can't recover on the street or under a bridge. So providing those types of places are important for our folks.
And just to add to that, for the health research nerds out there like me, we had done a systematic review of some of the literature on medical respite programs. This was a few years back, and so there weren't as many studies back then, but even back then in our systematic review, we found that medical respite seemed to be associated with reductions in future hospital admissions, inpatient days, and hospital readmissions.
And I think it's important to add that with COVID-19 long haulers, lots of folk are being released from the hospital, but they have problems that are associated with COVID-19 that are going to continue. They're not sick enough to stay in the hospital, but they're not well enough to really function. So the specialized nature of healthcare as a result of COVID-19 has meant that we're really looking at this particular option as one of the most important ways in which we can continue to provide care for that population.
Thank you all. Yeah, this transitional care seems incredibly important. Moving on a little bit towards a separate topic, we mentioned with regard to redlining and the history behind this, that in 1968 the Fair Housing Act was passed, and this was meant to alleviate some of the issues that were created by the 1934 New Deal plans. And so, Dr. Fullylove, can you tell us a little bit about the impact that the Fair Housing Act had? Did it make a large difference in housing equity that we were hoping it did?
I think the big issue is that it came a little too late. By 1968, much of white America had built up a substantial amount of wealth because of the ways in which housing policies were operating. So by 1968, after everybody had kind of picked the cupboard bare, you suddenly say, okay, I guess we can leave some for the rest of you. And not surprisingly, it hasn't been enough. So the notion that this might somehow do what was necessary to eliminate ghettoization and highly segregated urban America, no, it did not help at all. The 2020 census is going to reveal that we're really not a melting pot as a nation. We're much more a tossed salad. And as someone said last night, a TV dinner, one person and one group here, another group there. No, it hasn't done very much at all to eliminate segregation as a major understanding of how American cities are constructed. And the healthcare issues that are related to that are naturally very much tied up in the fact that 1968 did not do enough to assure that everybody would have equal access to both healthcare and to the kind of resources that promote health and prevent disease.
Thank you. Yeah, and on top of the systemic issue, we also have a great deal of issues with our overall national health system that contributes to all of this. So honestly, I'd like to hear from you all. I'll start off with you, Dr. Doran, on what you think sort of the overall impact that our national health system has on these issues, including homelessness, but also other issues. Does this play a role in patients experiencing homelessness?
I mean, certainly, and not to be too flippant about it, but I guess I'd ask, like, what national health system? We don't have a national health system in the US, and that certainly greatly affects people experiencing homelessness. And, you know, as Dr. Fullylove mentioned, you know, we have this TV dinner. I like that analogy, very segregated society, and the medical care is segregated as well.
Yeah, I mean, I would just agree. I think, you know, what we see across our health centers and what and you know, the care that's being given to the populations that might have been redlined or in those neighborhoods is drastically different. And you know, again, I can't emphasize enough that it's a failure of systems. Our systems are fragmented. This is not an individual's failure. This is not, the onus is not on the individual. So, you know, looking at, and I really appreciate Daniel Dawes' reference to political determinants of health, is really kind of getting back to that higher level of, you know, where do we need to make the change? What do we need to dismantle? What do we need to approach? Because they impact policies that a lot of our healthcare system either does or does not have control over. Healthcare providers are trying to take care of an individual, but might not have the advocacy or need to change the policies that they're trying to fight and advocate for their patients as well. So, so I just think that that's an important piece to kind of what we're seeing in segregation. And I think representation of the workforce is important too. Who's represented in the workforce can also add to either alienation or groups feeling segregated. And so I think that needs to be improved as well. And we need to have more individuals with lived experience, not us, not the providers, but those with lived experience that can identify, that can help bridge those gaps to link segregated populations back into a healthcare system. And I think that's an important conversation to have and programs to put in place.
I couldn't agree more. And Dr. Boyer, I love that political determinants of health reference, because I think that's exactly what we're looking at. As a nation, we've accepted homelessness as part of the condition of American life. So what we're talking about is, okay, we've got homelessness. What do we do about the medical problems that are created by this condition? A more rational society would say what we have is a problem with housing, and the fact that we really don't have federal policies that assure that every American can be safely domiciled. So accepting homelessness means that we've abandoned responsibility for dealing with issues of housing. And one hopes that COVID-19 and its aftermath, where so much has really demonstrated the problems of housing insecurity, that will actually start to have national policies that focus on housing, and as a consequence, reduce some of the issues related to segregation and homelessness. I mean, that might be something of a pipe dream, but I do believe that we're clear we can't go through another pandemic like this. And the best way to deal with prevention is to absolutely function on really, really important core issues like this, and do what's going to be necessary to make sure that we're better prepared for what is clearly going to be a part of our future. At least that's my hope.
Thank you. Yeah, and I love what you said, Dr. Phil. I love that housing is the real issue right here, that we have an issue getting people into houses, and there's always that statistic that the United States has enough houses available for to house all the homeless people that we have. And so, and thank you for that. And talking a little bit about sort of pandemics and epidemics that have gone on in this country, can you tell us a little bit about the HIV epidemic and how has that affected communities of color and even homeless populations?
Oh, in so many ways, everything that we've described has, at least for me, origins in HIV and our inability to really manage what should have been a preventable infection. Number one, rates of HIV in homeless populations are substantially larger, substantially greater than they are in domiciled populations. Folk who are living with HIV and who are being treated for it are going to have much more horrific outcomes if they're poorly domiciled than if they're, appropriately housed. It's very, very clear that HIV is a disease of marginalized communities. So who is more marginalized in our society than folk who cannot maintain their presence in a house? So once again, we're looking at a pandemic that had much of the fuel that produced it being created by a lack of appropriate federal policies to take the risk that is so much a part of homelessness out of the equation of who's going to be exposed to HIV and who is not. One could also say a great deal about the large number of folk in prison who are living with HIV, because if we're looking at one of the products of the social control of segregated communities, where in my state, New York, you're going to see 80+% of the population of the state prison system here, not only being from cities, but also being Black and brown. For many, many years, New York State led all state prison systems with respect to the number of people inside who were living with an HIV infection, 3 times 5 what it was in the mainstream population, if you will. So once again, everything that we're talking about obviously has so much to do with how much a society like ours depends on its functioning on the level of housing that it makes available, especially to people who are at risk for a wide variety of health conditions. Much of public health, I think it's fair to say, is driven by issues related to housing and homelessness. And I'm glad we're having this conversation, because I think at this moment, with our struggles with COVID-19. This is the time to really talk about it, because it might be the moment when we can get the rest of the nation to agree, yeah, we should be about this. We should be fixing this.
Thank you. Thank you so much. And on to a different epidemic that happened in the United States. The opioid epidemic has been going on for quite some time now. Dr. Jordan, I know you do some work on this subject. Can you talk to us a little bit about how the opioid epidemic has affected the homeless population?
I can. It's had a huge effect that really isn't often talked about. And it's overdose in general, not just opioids, is now the leading cause of death among people experiencing homelessness in the United States. Basically, every place that's looked at what are the leading causes of death. So New York City, Los Angeles, San Francisco, you name it. But then in general, homelessness and housing instability are under-recognized when people talk about the overdose crisis or the opioid crisis. It's not in the kind of mainstream circles talking about that, it's not often recognized how much of an intersection there is and an influence of homelessness and housing instability. But for example, in Massachusetts, when they did research, they looked at all the people in the state that had an opioid involved death, and they found that 15% of them had recently been homeless. So there's a big overlap here.
And I would just also add, one of the things that, you know, we focus on too in healthcare for the homeless is just kind of harm reduction approaches. And we aren't seeing everybody accept that, because I understand that that can be hard, but we have to have lower barriers. You can't put abstinence necessarily on something when someone's actively using. You know, the trauma that they're experiencing on a daily basis of just being homeless is enough. And so until we can kind of start meeting people where they are, and being okay with either, you know, needle exchanges or things like that to reduce risk, and then start moving things along, we have to start changing our mindset and becoming more accepting of alternative methods to this population. But yeah, that's all I just wanted to say. And then just there was another note earlier that I was thinking about too when we were talking about housing and health and criminalization, is that people get stuck in a cycle if they have misdemeanors that are many years older. And I know Dr. Full-Love, you can definitely talk to this more than I can, but they get denied housing through different voucher programs. And that can be, you know, misdemeanors that were expunged. They can be, you know, small offenses, but it really prevents them from getting housing because they don't qualify. So you get stuck in this cycle of poverty and this cycle of criminalization. But I just wanted to add that point to an earlier conversation we were having. So.
And it's really important to add that this had an impact on families for a long time. It's changed. Federal policy meant that if in the state of New York, for example, if your felony was related to a drug-related arrest, then not only were you denied access to Section 8 and housing and public federally financed housing projects, your family could be denied as well if they brought you in. So one of the major reasons why you have so many female-headed households, especially in Black and Latinx populations, is because if the father was somebody who was doing time in prison, bringing him into public housing also meant that you were risking everybody becoming homeless. So one of the factors that really has contributed to so many kids who are impoverished living in female-headed households has a great deal to do with this issue related to the level of incarceration that exists in the community and housing policies that basically exacerbated our efforts to keep families together. No, it's all tied in. And once again, homelessness as something that is a risk that people will do a lot of things to avoid has meant that many poor people have paid the price for something that should have been resolved at the federal level.
Thank you. And we just had one last question regarding COVID-19. So we've been talking a lot in recent news about vaccination efforts. How have these issues been affecting vaccination efforts? We've talked a little bit about how they've been affecting the virus has been affecting the population as a whole, but how has vaccination efforts been?
From the health center standpoint, our healthcare for the homeless centers, they're doing vaccination events. There's mass vaccination events to reach our population. Again, really kind of emphasizing the need for street medicine and street outreach groups to reach individuals. I think there's still a level, and I don't like the word vaccine hesitancy, because the onus is not on the individual, it's on us to build the trust, right? But we are seeing vaccination rates. I get sometimes frustrated because the conversation was thinking like, oh, well, J&J is going to be better for our population, which all of them are really great, but people should still be allowed to have a choice in the types of vaccinations that they get. But we do rely heavily on the J&J just because it is one dose. There's lower needs for it to be refrigerated or those types of things. So, we're seeing vaccination rates, individuals are getting vaccinated, and we're seeing those numbers increase. But, I think there's still more work to do. I think we saw, the release of the vaccinations to our health centers were not necessarily equitably distributed, which was a little frustrating. So we saw things going into rural areas that weren't necessarily, in the highest level of need in the early on stages of the vaccination release. And so, there were some inequities that were happening there. And so we weren't seeing vaccines going to higher populations in urban areas where the need was higher. So there've been some systemic issues there in the distribution that we're still working through, but I'll let others chime in.
Yeah, and I would just add, people in the field are people working in homeless services and healthcare services. They're going to great ends to make it work. In New York City Health and Hospitals recently started bringing out mini buses to meet people where they're at, where they can also have the vaccine refrigerated. I know in Boston, they were wheeling around little mini refrigerated suitcases, getting people vaccines. But, in the end, and this alludes really to the whole conversation, isn't it kind of sad that we have so many people who are homeless, whose very condition of being homeless makes it so that we need to be doing all this like twisting in circles and jumping through hoops just to be able to deliver one of the very most basic elements of healthcare, vaccines, to people? And wouldn't it be better if perhaps we didn't have a society where we had 500,000 people who were homeless?
Yeah, and thank you for saying that, because you remind me too, in the early rollout, part of the challenges that we were seeing is that we didn't have a national prioritization. So states, and so we're seeing that with our health centers too. So while we're getting, our health centers are getting guidance and instructions from Health and Human Services and Health Research Services and Association, they're still fighting the prioritization that's locally in their state. And so really trying to advocate for that. So I think there were some challenges in terms of that as well.
Thank you all so much. And I think that was the end of our questions. I'd like to leave just a minute or so just for some final remarks. Our audience is our medical students who are going to be going into their clinics, going to be going into their residencies, but may also be policymakers in the future. And so what last remarks might you have for the medical students? Dr. Doran, let me start with you.
Sure, so many. I mean, I would say, do use your voice as a physician to advocate for the policies that are needed to make the system better. From a very personal level, you try not to get too jaded. We know from past research that people's attitudes towards homelessness actually get worse as they progress through medical training, from medical school to residency to becoming an attending, which is due to a combination of factors, but is obviously the opposite of what we want. And I think my best advice on a level as you as a physician is just to listen to people, to ask people about their housing rather than making assumptions, to be non-judgmental, and to help people and ask people what they need. People going through homelessness are often among the kindest, most giving people around, and they'll help you to learn if you are non-judgmental and if you're listening.
I think I'd want to say that, number one, I come from a long line of physicians. My grandfather started practicing medicine in Mississippi in 1907. My father started practicing medicine in 1934. Mindy Thompson Fuller started practicing in 1978. We've been very connected to Black communities that have been medically underserved throughout that period of time. And of all the things that I think we want to make clear is that we're too much in this society about the business of labeling. You cannot have labeling the patient be the way in which you approach the patient's healthcare. They are not their labels. I'm going to say that again. They are not their labels. The map is not the territory. You will become a better physician by really understanding who the patient is, not what the patient is. And if you can see that as more than 100 years of advice from a family that has been very concerned about serving communities like this, understand that it is the best way forward. And I hope you get a chance to adopt it.
Yeah, and I just echo both of what Dr. Duran and Dr. Full said. I mean, I think for me, it can be tiring. I think we see a lot of moral injury with our providers, and so. But I think, as long as we continue to fight systems, you're not alone. I think there's organizations that can do the advocacy for you, with you, because it's hard work, and it can be hard. So I guess I would tell students to just manage their self-care. We're seeing a lot of burnout, and so, but it's so important, the work that we're doing, because healthcare is a human right and every individual deserves healthcare, and every housing is a human right. So, I think if you just keep on with those morals and that vision and mission, just know you're not alone in that. So good luck with everything.
Thank you all so much. I really appreciate you all coming, and I think our students are going to learn a lot from this.